Distinguished Professor and College, my name is Trương Quỳnh at University Medical Center, Ho Chi Minh City. It's my honor to present our study entitled The Value of MRI in Predicting Response to Neoadjuvant Chemoradiotherapy in Rectal Cancer. Colorectal cancer accounts for 10% in new cancer globally, ranking the 5th in Vietnam. Guidelines like ESMO or NCCN recommend total mesoexcision combined with preoperative neoadjuvant chemotherapy or NCRT for local advanced diseases. NCRT helps downstage tumors, improve resection rates, and preserve the anal sphincter. So, chemoradiotherapy is one of the important treatments. However, the degree of response to the neoadjuvant therapy among patients is not uniform. Studies show that 10 to 27% pathologic patients achieve pathologic complete response or PCR. These patients have a local recurrence rate, distant metastasis rate significantly lower, while 5-year survival rate after treatment significantly higher. Patients who achieve PCR may consider for less invasive surgery. In addition, according to updated treatment guidelines, several centers have adopted watch and wait strategy, offering a comparable control and improve the quality of life. Therefore, identifying PCR to chemoradiotherapy is crucial, and MRI is promising, not only for staging after treatment, but also for predicting PCR, supporting prognosis and treatment options. So our objective is identify predictive factors and build a model for PCR after NCRT. We conduct a study on patients who had MRI before long courses NCRT, followed by surgery and pathological examination with 2 groups. PCR group are YPC0 and 0, and non-PCR groups are the others. About the result, after 92 patients in our study, 21.7% achieved PCR. Our result was consistent to some study, though others report higher or lower rates. About the age, gender, pretreatment CER, and histologic grade, we found that they're not associated with PCR. Regarding to MRI features, the distance from the lowest boundary of tumor to anal spurt or maximal tumor height had no significant difference between 2 groups. In our study, tumors achieved PCR were thinner. A cutoff of 1.3 cm or less predicted PCR with a sense of 60% and spec of 73.6%. PCR group had significantly smaller, largest cross-sectional tumor area on axial plane compared to the non-PCR group. An optimal largest cross-sectional areas of 5.2 square centimeter predict PCR with sense of 60% and spec of 84.7%. Relative cylindrical tumor volume was smaller in PCR group. A threshold of 20.2 cubic centimeters predicted PCR with sense of 55% and spec of 80.6%. In our study, circumferential extent, CT stage, mesorectophasia and were not significant. However, the absence of EMVI before treatment was significantly associated with PCR. In our study, 14.1% had no nodal metastasis. Mesorectal node significant difference between 2 groups, while extra mesorectal node show no difference. Regarding to lymph node meeting imaging criteria for metastasis, PCR group we have average 2 nodes versus 5 in non-PCR. The cutoff of 2 nodes or less predict the PCR with a sense of 70% and spec of 69.4%. In contrast, sock axis diameter of knot show no difference. And we can see lab and histopathological factors show no correlation, while significant MRI predictors include EMVI negative with the highest sensitive, absence of knot with the highest spec and positive predictive value, and the number of lymph nodes meeting imaging criteria for metastasis with the highest negative predictive value, and our strongest predictor is no lymph node. We built a multivariate logistic model to identify independent predictors, including largest tumor area of 5.2 square centimeters and the number of lymph node meeting imaging criteria for metastasis, and the final model with AUC value of 0.812 with a sense of 70% and spec of 80.6%. To facilitate clinical application, we built a nomogram combining variable score with total score indicating the probability of PCR. For example, a tumor with the largest tumor area with the equal 40 points, giving a PCR probability less than 10%, with 4 metastasis nodes. The total score now is 40 points plus 75 points equal 115 points. We have the probability of PCR approximately 40%. In contrast, if we had no lymph nodes, we have the total score now is 140 points, corresponding to probability of achieving PCR is over 65%. In conclusion, pre-treatment MRI provide valuable predictors for PCR in rectal cancer, supporting treatment decision making. Thank you for your attention.